So the question was whether inflammation plays a role in MPNs, and also the title given already proposed that there's a cause and effect of inflammation in MPNs and vice versa, and that's really what I tried to show, and this is the case. And I started with the question of which of the inflammatory cells in the bone marrow and in the peripheral blood are involved in the malignant clone. And interestingly, we see that quite a lot of different cell lineages can be involved in the JAK mutation, harboring the JAK mutation in MPNs. Then the second aspect was that MPN clones and MPN cells hijack their normal counterparts to become inflammatory and contribute to the inflammatory disease. And the third aspect was targeting inflammation with anti-inflammatory drugs or even pro-inflammatory drugs like interferon has been shown to be beneficial for the patients, probably because of effects both on the malignant clone and on the bystander inflammatory cells. Interestingly, it was found that not only hematopoietic cells belong to the malignant clone, but the JAK mutation was also found in endothelial cells, and these cells were then functionally analyzed, and it's been shown both in the human systems but also in mouse systems that the endothelial cells can be activated by the mutation, and they contribute both to thrombosis, inflammation, and even bleeding. And there's a close interplay with the hematopoietic cells. And on the therapy side, we now know that having access to clinical trial data from JAK2 inhibitors and JAK1 inhibitors, both selective and unselective, that probably symptoms can be alleviated well by all of these drugs, but the splenomegaly can be best reduced by inhibition of either JAK1 and JAK2 or JAK2 alone. And we have, I showed some data that we will go into more detail at ASH, I proposed some data to show at ASH that we have evidence for a cross activation of the JAK1 pathway by the JAK mutant and not by the CALR mutant, and this may be important then for interferon treatment, since we are showing that the JAK2 mutation can activate or predispose cells to an interferon response. This is not done in to the same extent by the CALR mutation, and this may explain why clinically we may have to use higher doses of interferon in the CALR patients. There's still a lot to do, and large registries and clinical trials as well as translational research are still desperately needed to improve the care of our patients.